Hello everyone and welcome to the second lecture in the interesting topic of culprit, vessel and lesion in STEMI, and today we are speaking about the culprit in lateral STEMI. Today we are going to understand how to localize the culprit artery and culprit lesion in patients with lateral STEMI. Of course, before we begin, we need to mention again the following ECG features suggest the culprit lesion in the majority of patients, but they are not solid rules in all patients due to anatomical variations between individuals or in some cases due to presence of pre-existing collateral circulation. Let's remind ourselves again with the coronary anatomy, which is important to understand our lecture today. We have the left main bifurcating into LAD and LCX. LAD gives the diagonals and the septa perforators, and the LCX gives origin to the obtuse marginal branch which supplies the lateral wall. We have also right coronary artery which gives origin to the coronal branch, RV branch, and then it bifurcates into posterolateral branch and PDA. And so today we are focusing on the lateral wall infarction, which is termed the lateral STEMI. Of course, we mentioned before that in 70% of the population, the RCA is the dominant vessel as it gives origin to the PDA, which in this case is right-sided PDA arising from the RCA. And in this case, the RCA supplies the inferior wall and posterior wall, and the LCX only supplies the lateral wall of the heart. In 10%, the LCX is the dominant vessel giving origin to a left-sided PDA as its continuation, and in this case the RCA is a small ending before the crux, and so in this case the LCX can supply lateral wall, posterior wall, and inferior wall of the heart. And in 20% is co-dominant supply between the RCA and LCX with right-sided and left-sided PDA, so they share in the perfusion of the inferior wall, lateral wall, and posterior wall. The diagonal branch, as we mentioned before, which arises from the LAD, supplies the lateral wall of the LV together with the LCX. That's why LAD occlusion proximal to the first diagonal can cause lateral wall infarction together with the anterior wall, resulting in ST elevation in anterior leads beside one AVL and or V5, V6. And if there is isolated occlusion of the diagonal branch, it can result in lateral wall infarction with ST elevation 1 AVL and or V5, V6. We have also left main trifurcation in about 15 to 30% of patients, as we have the ramus intermedius arising between the LAD and LCX, which can behave like a large OM or large diagonal, so it can supply also the lateral wall as the LCX and as the OM branches. We mentioned also that the SA node receives its plus supply in 6% of the population from RCA and in 40% from LCX, whereas AV node in 80% from RCA and 20% of LCX. So LCX shares in the plus supply of the SA node and AV nodes. We divided the walls of the left ventricle into basal, mid, and apical segments. We mentioned that there is the anterosuperior wall and anterior septum, which receives their blood supply from LAD, posterolateral wall, which receives its blood supply from LCX, and the inferior wall, which receives its blood supply from right coronary. And we mentioned that these nomenclature correspond to the walls of the left ventricle. Lateral wall infarction, of course, can be isolated, and in this case is called lateral STEMI, and it can be associated with anterior wall infarction as the original infarction, and so it is called anterolateral STEMI. Of course, the culprit artery in lateral STEMI is mostly the LCX territory, and in anterolateral STEMI mostly it is the LAD territory, and anterolateral STEMI is much more common than lateral STEMI. So lateral wall infarction, in most of the cases, it would be combined with another territory like the anterior wall infarction, and it is less common to be isolated. We need to mention that lateral wall is electrically silent in comparison to the anterior wall and inferior wall, and that's why lateral wall infarction can be easily missed, especially if isolated. And when it is additional to another type of infarction like anterior wall or inferior wall, it may be forgotten as a risk stratifier, of course, which add to the magnitude and to the clinical risk of MI as an anterolateral infarction. That's why sometimes lateral wall infarction is missed, and so it is not electrically represented in the ECG as the other walls. ST elevation, of course, in V5, V6, and in 1 and AVL, whether the 4 leads are involved or just 2 of them, is called lateral STEMI if it is isolated, And so lateral STEMI, although it is less common than anterolateral, for example, but of course it is not uncommon to see in your practice ST elevation involving the lateral ECG leads alone without other additional leads. There is of course subclassification of the lateral STEMI. When the involvement here is involving only V5 and V6, which are the most lateral precordial leads, it is called lateral STEMI, as it involves mainly the lower region of the lateral wall, whereas when it involves 1 and AVL, here it involves the superior region of the lateral wall, so we call it high lateral STEMI, as 1 and AVL are considered to be the high lateral leads in comparison to V5, V6. So of course, don't be astonished or confused when you hear these two nomenclature. These two terminologies are both subtypes of lateral STEMI according to which lateral leads are involved. If we need to mention the perfusion of the lateral wall, so we can enumerate them as the LCX proper, or in branches of the LCX as a direct source of blood supply to the lateral wall, diagonal branches of LED or ramus intermediates in 15 to 30% of patients. And so any one of them can be a culprit artery in lateral STEMI. So lateral STEMI in ECG denotes that the culprit artery, of course, is the LCX proper or obtuse marginal or diagonal branch or less common ramus intermediate. So these are the main possibilities for the culprit artery in patient with lateral STEMI. Lateral STEMI, of course, when we think of the culprit in it, mostly it is LCX proper or sometimes one of its branches. High lateral STEMI, we usually think of OM branches or diagonal branches, although of course it is not a must, but which is more common in lateral STEMI, I think much more of the LCX proper, and in high lateral STEMI, I think much more of branches like OM or diagonals. We need to ask a question: does the LCX supply the lateral wall only? Of course, the answer depends on the fact whether this LCX is dominant or non-dominant. If it is non-dominant, it would supply only lateral wall, but if it is dominant, in this case, it can give supply to the lateral wall, posterior wall, and also the inferior wall. Posterior MI, of course, as we remember, can be diagnosed from the 12-lead series ECG by looking at the ST depression in V1 to V3 with tall R wave or RS ratio more than 1, and in the posterior ECG leads showing ST elevation more than or equal 0.5 mm in V7, V8, V9. And so the ST depression in V1 to V3 is like reciprocal depression in response to the posterior wall infarction. And we remember the position of V7, V8, V9 as the actual posterior ECG leads. And so in this case, we think of LCX as a culprit, or sometimes RCA, of course, if it is giving the origin to the PDA. And PDA sometimes may be rudimentary with a small caliper. So in this case, the inferior wall receives its blood supply directly from RCA or from LCX or from obtuse marginal. And so dominant LCX can give supply to posterolateral wall involving lateral wall and posterior wall, and also to the inferior wall. So don't be astonished if you see a patient having ST elevation involving lateral wall, inferior wall, posterior wall, and the culprit was LCX. Of course, it was a dominant LCX. So lateral STEMI is mostly caused by LCX occlusion, and LCX occlusion itself may lead to lateral STEMI involving ST elevation V5, V6, high lateral STEMI involving 1 and AVL, infralateral STEMI with ST elevation in V5, V6, 1 AVL plus the inferior leads, or infraposterolateral STEMI as the same, including also ST depression and RS ratio more than 1 in V1 to V3. But also it can cause isolated inferior STEMI, isolated posterior STEMI, or infraposterior STEMI in case of distal LCX proper occlusion. If the LCX, of course, was dominant and RCA was small, in this case, inferior STEMI can have the culprit vessel as LCX, posterior STEMI, and infraposterior STEMI. In some cases, the culprit can be LCX, so don't be astonished in this case. So remember, LCX occlusion can result in isolated ST elevation in inferior leads, and so it can be a culprit in inferior STEMI, especially if RCA is small sized, small caliper, and non-dominant. We need to understand the injury vector of lateral STEMI. Here, if the occlusion is in the LCX itself, so it results in lateral wall infarction, and here the injury current is directed toward 1 AVL, so mostly it would result in ST elevation 1 AVL, and it is away from the inferior leads, so here the reciprocal depression appear in the inferior lead, resulting in ST depression in lead 2, 3 AVF. So sometimes the reciprocal depression in the inferior leads itself may be the alarm that raise your attention to ST elevation in high lateral leads. Let's see this ECG example here. Maybe the first thing to get your attention is the ST depression and slight D wave inversion or slightly biphasic T wave in lead 3 AVF. So when you see this ST depression, of course, the first thing to look for is ST elevation. Here it is much more remarkable in AVL rather than in lead 1. So here it is not just ST depression, inferior leads diagnosed as non-ST elevation acute coronary syndrome. No, it is the high lateral STEMI, and that's why the reciprocal depression in inferior leads is very important to direct your attention toward lateral or high lateral STEMI. And remember, reciprocal depression in inferior leads are mostly seen with ST elevation in 1 AVL rather than V5 and V6, so mostly you would not see ST depression in inferior leads with ST elevation in V5, V6, because of course they are not in opposite directions to each other as 1 AVL. Now let's enumerate what does each culprit artery and culprit lesion produce in the ECG. When there is proximal LCX occlusion, I can expect to see ST elevation involving V5, V6, and or 1 AVL. So the 4 leads can be involved as the occlusion is proximal, but also it can involve just 2 of them. And I can expect to see reciprocal ST depression in inferior leads if the ST elevation was involving the high lateral 1 and AVL. And if there is distal LCX occlusion here, the ST elevation involves only just 2 of them, and the reciprocal ST depression occurs in the inferior leads in case of elevation in 1 and AVL. When there is isolated occlusion in the OM branch of the LCX, here of course the most common presentation to see ST elevation in 1 AVL or ST elevation in V5, V6, and this depends on the anatomical course of the occluded branch. So whether it would result in 1 AVL ST elevation or V5 and V6 ST elevation is according to which branch is occluded and what is its course, and of course reciprocal depression as well in inferior leads if the elevation was in 1 AVL. If there is diagonal branch occlusion, which is a branch from the LAD supplying the lateral wall, here the ST elevation mostly occurs in 1 AVL or in ST elevation in V5, V6 with reciprocal depression inferior leads, and of course which 2 of the lateral leads would be involved, it depends on which branch and what is its anatomical course. When there is a dominant LCX occlusion, so the LCX here gives origin to a left-sided BDA, it would not be only ST elevation lateral lead. I can see ST elevation inferior leads, I can see ST depression and RS ratio more than 1 in V1 to V3, indicating posterior wall infarction. So dominant LCX occlusion can result in lateral STEMI or inferolateral STEMI or posterolateral STEMI or infraposterolateral STEMI. So of course dominant LCX occlusion result in a large magnitudes of infarction, and this depends on the site of occlusion and the territory supplied by the dominant LCX, and according to this which one of them would appear in the ECG. Now let's revise them in a different and in a clinically applied way as the same way that we have performed in the lecture of anterior STEMI. When I see ST elevation in V5, V6 plus 1 in AVL, so here's the 4 lateral leads are involved, I could expect a large territory of lateral wall affected. So I can expect occlusion of proximal LCX proper due to involvement of a large region of the lateral wall. Also another possibility that the patient is having large sizable OM branch and his LCX proper is short with small caliper. So maybe this large sizable OM is occluded. Also another possibility is that there is an occlusion of a large sizable diagonal branch, as maybe the LCX proper and its OM are short with small caliper. So all these are three possibilities. Also another possibility is that it is just ramus intermedius, as in 15 to 30% of population, which can behave as a diagonal or than an OM branch. So it is the fourth possibility. So for example, here in this ECG, I can see ST elevation in lateral leads from V4 to V6, plus also 1 and AVL, and there is reciprocal depression in inferior leads. So I can expect proximal LCX proper occlusion, or large sizable OM occlusion, or large sizable diagonal branch occlusion. Another possibility, what about ST elevation in V5 and V6? I can expect to see occlusion in the LCX proper, in the OM branch, or in diagonal branch. So each one of them can be a possibility for localized lateral wall infarction in only V5 and V6. So for example, in this ECG, I can see ST elevation in V6 and there is ST depression in V5 and V4, which may give the appearance of the Winter syndrome in the lateral territory. Of course, they are not fulfilling the criteria for the Winter syndrome because the T wave is not hyperacute as in the classic De Winter syndrome, but here it may suggest lateral STEMI, and also there is like an evolving or starting elevation in 1 and AVL, although not very fulfilling the criteria. So here I can see lateral STEMI, maybe LCX proper occlusion, OM or diagonal branch, and here I cannot see reciprocal depression inferior leads because the elevation here is involving V5 and V6. Another famous possibility, what about ST elevation 1 and AVL, the high lateral STEMI? It may suggest occlusion of OM branch, diagonal branch, or maybe distal LCX proper occlusion resulting in a limited infarction in the high region of lateral wall. That's why we call it lateral wall STEMI or high lateral STEMI. For example, here we can see ST elevation in lead 1 and AVL, and there is also reciprocal depression in lead 3 AVF, and there is no any other ST elevation. So here I'm speaking about high lateral STEMI, which may be due to OM occlusion, diagonal or distal LCX proper occlusion. Another possibility is the ST elevation in lateral leads plus in the inferior leads, which we call it infralateral STEMI. Here, of course, this possibility raises the suspicion of dominant LCX, and there is occlusion in this dominant vessel, resulting in lateral wall and inferior wall infarction. For example, in this ECG, I can see ST elevation starting from V4 to V6, but also there is ST elevation in inferior leads. So this is an example here of ST elevation involving two territories calling infralateral STEMI, mostly caused by dominant LCX occlusion. Also another possibility is the ST elevation in lateral leads and posterior leads, which we call posterolateral STEMI. Also, it is a possibility of a dominant LCX resulting in infarction in the lateral wall and posterior wall. Here in this example, we can see ST elevation in 1 and AVL and reciprocal depression in inferior leads, but also there is ST depression starting from V3 to V5, which may suggest posterior wall infarction with RS ratio more than 1, but here there may be a shift in the position of that precordial leads, or sometimes the configuration of the heart is different between population, so the posterior wall changes here appear in V3 to V5. So here we have posterolateral STEMI caused mostly by dominant LCX occlusion. And here's the extreme possibility, of course, of ST elevation in lateral leads, inferior leads, and posterior leads. So here it is infraposterolateral STEMI caused by occlusion also of a dominant LCX. As in this example, we can see ST elevation in lateral leads, lead 1, V5, V6, and also ST elevation in inferior leads, and classic example of posterior wall infarction, ST depression in V1 to V3 or also to V4 with RS ratio more than 1 from V2 to V4. So here it is infraposterolateral STEMI, mostly dominant LCX occlusion. Another possibility is ST elevation in lateral leads with precordial leads. Oh, it is different. It is not just lateral STEMI, it is anterolateral STEMI, suggesting occlusion of proximal LAD, which of course here denotes that the occlusion is proximal to the first diagonal, resulting in anterior wall infarction and lateral wall infarction. So here it is an LAD, not LCX. As in this example, we can see ST elevation from V1 to V4 and also in 1 and AVL. So of course it is anterolateral STEMI with ST depression in AVR denoting proximal occlusion. So it is anterolateral STEMI occlusion proximal to diagonal 1 and mostly distal to septal perforator. Now it is time for the unique questions that we usually ask near the end of our lecture. Can the culprit in lateral STEMI be another vessel, not the LCX or the OM? Of course, the first two possibilities that we mentioned, diagonal branch and ramus intermedius, but also there is an exception in which there is chronic total occlusion of LCX being supplied by collaterals from LAD or RCA territory. So of course, in this case, the LAD or the RCA can be the culprit giving retrograde supply to the LCX. So the LCX here is chronic total occlusion, not the culprit vessel, and we mentioned this example before. Another question, can the diagnosis of lateral STEMI made without reciprocal ST depression? It is not very common to see this example, but also it is a possibility. In case of very distal LCX occlusion or slow flow in the LCX as a main pathology, ST elevation may appear without reciprocal ST depression in inferior leads, so it is not a must. Sometimes the reciprocal depression inferior leads can be replaced in patients with lateral STEMI by ST elevation, and so it is called infrolateral STEMI, as we have seen in this ECG example. There is no ST depression inferior leads, it is infrolateral STEMI, but of course here the elevation is in the lateral precordial leads, not in the high lateral as expected. So remember, presence of reciprocal ST depression is a confirmatory sign for STEMI, but it is not a must for diagnosis, because sometimes you have caught the patient at an early stage, so you may be seeing minimal elevation in the high lateral lead and there is still no ST depression in inferior leads, so don't omit the diagnosis just due to the absence of reciprocal ST depression. Another question, can lateral STEMI be associated with bradyarrhythmia? Of course, we mentioned before that the blood supply of the SA node and AV node may come from the LCX territory, but of course it is not common as in inferior STEMI. So in lateral STEMI it is a possibility to see sinus node dysfunction or AV block, but it is not very common as in inferior STEMI, although it is still a possibility. The fourth question, can infrolateral or infraposterolateral STEMI be caused by RCA occlusion? It seems weird, but also it is a possibility, because sometimes the patient have large caliper dominant RCA with big sizable PDA and posterolateral branch that extend to the posterior wall lateral wall, and his LCX is small caliper and non-dominant. So in this example, the patient here can develop posterior wall infarction together with the inferior wall infarction and together with lateral wall infarction caused by RCA occlusion, not dominant LCX occlusion. So RCA occlusion may be a possibility, although not very common, to cause infraposterolateral or infralateral STEMI. And so if we ask another question, can posterolateral STEMI be caused by RCA occlusion? Yes, of course. If there is large caliper posterolateral branch occlusion with small caliper and non-dominant LCX, in this case, the patient may have lateral wall infarction together with posterior wall infarction, resulting in posterolateral STEMI caused by posterolateral branch occlusion, not the LCX. So let's summarize again. Here's a lateral wall infarction. It can be isolated with anterior wall or with inferior wall infarction. If it is isolated, it is called lateral STEMI, and mostly the culprit is the LCX or OM or diagonal or ramus intermedius. If it is with anterior wall infarction, of course, it is called anterolateral STEMI, and here the culprit is mostly the LED. If it is with inferior wall infarction, it is called infralateral STEMI, or sometimes it is infraposterolateral, and here the occlusion is in the dominant LCX mostly, but also it may be dominant RCA. And if we need to summarize the posterior wall infarction here together with the lateral wall, it can be isolated, resulting in isolated posterior STEMI. It can be with lateral wall infarction, it is called posterolateral, or with inferior wall infarction called infraposterior STEMI. And all of them can be caused by dominant LCX occlusion, the LCX proper itself or its OM branch, or dominant RCX occlusion, either RCA proper, its posterolateral branch, or its PDA occlusion. And our tip near the end of the lecture: any ST elevation or ST depression in a patient with chest pain gives you a clue, even if not fulfilling the criteria. So please, when you analyze the ECG of a patient with chest pain, pay attention to HST elevation, HST depression in any lead, whatever the magnitude. So at the end of our interesting lecture today, we understood how to localize the affected culprit lesion in patients with lateral STEMI, and our take-home message today: LCX territory, of course, is the first possibility to think of as a culprit in case of lateral STEMI, but you need to look for other possibility as diagonal branch, ramus intermedius, or sometimes even distal RCA territory occlusion can be cause of lateral STEMI. Thank you very much for your watching.